We're studying Chapter 8 on articulations or joints in our text of Human Anatomy and Physiology. This is Part 2. In Part 1, we looked at different types of synovial joints, different classifications of joints. I shouldn't have said types because we're going to reserve that term for this section. But we looked at some classifications of synovial joints, and then we looked at some different types of movements allowed. Now, there's a lot of ways you can sort of describe the types of a joint and the movements of joints. So let's dive right into this Part 2. We're first going to look at these types of joints. We're kind of general categories in a way, and then we'll look at the type of movement that's allowed by each one of these types of joints. So we're going to try to look at the range of motion and the type of movement. You'll see what I mean. So here we have our first category, our first type of joint, a plane joint, in which there are flat surfaces between the articulating bones, such as with the carpals and tarsals. We've mentioned this before already. The type of movement allowed is a gliding movement. And the range of movement is a non-axial movement. There's no axis around which these bones move. They can glide in any direction, essentially. Our next type of joint is a hinge joint. And in the example given here is the humerus and the ulna, forming the elbow joint. Here is the trochlea of the humerus that articulates with the olecranon process of the ulna. It's called a hinge joint because it's a uniaxial joint. The movement occurs as the two bones remain in the same plane. So just flexion and extension are the movements that are allowed. These are terms that we had in the previous section in terms of describing the types of movements. Uniaxial, though, is another way of describing the type of movement in that there's, again, one plane. The axis of about which the bones move, the joint moves, is in one plane. A pivot joint also is uniaxial. There's movement around one axis as the bones do their thing at the joint, but in this case, it's rotational motion. It's the type of motion or movement that's going to be produced. So the example given here is the radius articulating with the ulna, and when we pronate and supinate the hand, what's happening is at the proximal end of the radius, there's rotation happening in this pivot joint. Next, we come to condylar joint. Now, it's kind of strange because we've used the term condyle to mean just generally a joint surface, but we'll leave it alone. Condylar joint is this sort of oval cup, almost like a ball and socket type joint, which is, I'm jumping ahead a little bit, but sort of a cup-shaped joint here. And an example given is the metacarpophalangeal joints in your digits of your hand. So the base of your fingers, there's a condylar joint between the metacarpal and the first phalange, or phalanx. So in this case, there's more than one axis about which the joint can move. You can imagine that we can flex and extend the digits. So where's my camera? And we can also abduct and adduct the digits, and so we have this so-called biaxial movement. If you use your imagination, you can see that there isn't quite a biaxial limitation of this type of joint. These surfaces do not preclude unusual angles of movement of the digits, but anyway, I digress. Here's a little bit deeper version of maybe of a condylar joint, a saddle joint. There's just one example. It's the carpometacarpal joint of your thumb. So the base of your thumb is a saddle joint. It also allows biaxial movement, adduction and abduction, as well as flexion and extension. It's just a little deeper and more stable joint than the joints of the four digits, the other four digits. Now we come to the ball and socket joint. This joint produces the most freedom of movement of all the synovial joints. And this particular example provides the most range of movement of the two ball and socket joints. Multi-axial movement. There's really no limit to the number of axes through which the movement can occur, and we've also made this connection that the more range of movement a joint can produce, the less stable the joint is. So yes, indeed, this is a very unstable joint, as we'll discuss in just a bit. So that's called a ball and socket joint. This is the glenohumeral joint, the glenoid fossa or cavity, and the head of the humerus articulating in the shoulder. The stability of joints. Well, as we said, the skeleton is extremely stable. The joints represent the weak link. They're much less stable. The joints sort of occupy a little bit more geography. They're a little bit broader than the bones typically are in the diaphyses of long bones, for example. These synovial joints I'm mainly thinking of, to give a little more stability, but still joints are inherently unstable, synovial joints. The things that do provide the stability that joints have is the shape and construction of the joint. So if we look back to, say, the elbow hinge joint, there's a fair amount of structural sort of definition here in the olecranon process and the trochlea of the humerus. So that to some degree provides stability. In other words, it defines where the joint can go, where the bones can move. There's ligaments surrounding and within, many times, the synovial joints that add some additional, much more stability. Dense, regular connective tissue attaching the bones together, really limiting what they can do, so that we don't get things out of position relative to what the movement is supposed to be available. And finally, the most important source of stability for joints is muscle tone. Muscle tone refers to a state of constant partial contraction of your muscles. Your muscles aren't ever completely relaxed, or not typically, especially if you exercise regularly. There's a little bit of tension there all the time, and that's what kind of pulls those bones together in the joint. The muscles cross the joints in order to be able to move the bones about the joint, and they pull the bones together at the joint. So muscle tone is hugely important for joint stability, and hence avoiding joint injury. So how important is it to exercise your muscles so that they're strong and you have good muscle tone? So those are very, very important things you can do to prevent joint injury and maintain joint stability. If you do suddenly increase an exercise regimen or get into an exercise routine suddenly from a state of inactivity, because you haven't gotten the muscle tone up and strengthened the muscles prior to that happening, there's a number of types of injuries that can occur. So you don't want to get into that situation. For example, if you just jump up and haven't been doing anything but watching, binge watching your favorite television shows for weeks at a time, maybe even months at a time, and you jump up and go out and do a long run outside, you're probably going to have pretty sore knees. So that's a bad idea. Better to get some strength in there and stability, and also do something to reduce inflammation in the joints, which is another benefit of exercise. So now we come to a couple of joints, specific joints in the body. We can take a look at their construction, and they're extremely fascinating. We've been observing the movements of our body all our lives and have quite a bit of an idea of what the normal range of movement is and so forth, but let's look at the actual construction of the joints. Here's the knee joint. The femur has a rounded end which just rolls on the top of a flat table of the tibia. So you basically have a flat tabletop and a rounded bone that has to go through this movement in which there's only a little bit of this curve sitting on the tibia at any one time, but it needs to remain in a position directly atop the tibia. So you may ask yourself, how in the world does this round structure not just slide off anteriorly or posteriorly of the tibia, the way it's pictured here? And the answer to that is two ligaments that pass through the middle of the joint cavity, the cruciate ligaments, the anterior cruciate ligament and the posterior cruciate ligament. Let's see, I believe they're mislabeled here. I think they're switched. Nope, they're good. Anyway, the anterior cruciate ligament, you've probably heard of that before, and we're going to take a look at it in just a bit, but it keeps the femur from wandering posteriorly, or we could say the tibia from running out ahead of the knee joint and separating the bones that way. So the anterior cruciate ligament it prevents that movement. The posterior cruciate ligament prevents the opposite separation of the bones. We can see a number of interesting things going on in addition. You can see the patella, the kneecap, and the patella is a sesamoid bone, S-E-S-S-A-M-O-I-D, sesamoid, because it lies within a tendon. So here are the quadriceps group of muscles and their tendon, and they attach to the patella, and there's a ligament then from the patella that attaches itself onto the tibial tuberosity of the tibia. And so here's the sesamoid bone right in the middle of this dense regular connective tissue. But you can imagine as you extend or straighten your knee, especially when your body weight is placed on it, all the strength to do that comes from the thigh muscles, and excuse me, that's going to draw the patella posteriorly onto the femur, and there's an articulation there. There's some articular cartilage you can see here on the patella, and it must articulate with the anterior of the femur here. There's some collateral ligaments also present around the knee, as we'll see in a second, but a little tiny bit of the meniscus is shown here, and I think this is not the best diagram to really talk about the meniscus because you can't see too much of it, but also take note that there are bursa in the knee joint to prevent rubbing of structures. For example, the deep infrapatellar bursa here to prevent the patellar ligament from rubbing on other structures in the knee joint. Here's a superior view of the tibia with the femur removed. We can see the anterior cruciate ligament and the posterior cruciate ligament have been cut away to do that. And here now you can really see the menisci, crescents of fibrocartilage that act as shock-absorbing pads within the knee. The femur essentially has two separate joints, two separate condyles, which are each of which articulate with the tibia, and underneath each one of those condyles is a nice fibrocartilage pad called the meniscus. It sits on top of some hyaline cartilage that's directly in contact with the bone. Here's a picture that shows you, maybe gives you an impression of how effective muscle tone may be. Look at the dimensions of this muscle group, 4 muscles that have a tremendous mass and that can produce a lot of muscle tone to keep the knee joint pulled together. You can see that here the patellar ligament down here and the tendon of the quadriceps muscles, and there's the patella in the middle of things. So really going to have some strength to pull those things together all the time, no matter what position your body happens to be in. We can also see there are some collateral ligaments running outside the joint that hold things together. The tibial collateral ligament on the medial surface, and the fibular collateral ligament on the lateral surface, as well as the lateral patellar retinaculum and medial patellar retinaculum. So these ligaments all help with the cruciate ligaments to hold the knee joint in place so that we have good stability for the knee joint, but the majority, again, of stability comes from these enormous muscles, and there are other muscles crossing the knee joint that contribute to that stability. There's just another cutaway drawing showing the knee from the posterior, and you can see the two heads of the gastrocnemius muscle, the more superficial of the calf muscles, cut away here, and some more of the ligaments that sort of wrap up the knee joint and provide stability. The joint capsule is also visible here, the fibrous capsule of the joint. You can see another little bursa tucked in there. Here you can see how the patella, really can see how the patella articulates with the femur. There's a ridge on the patella lined with articular cartilage, which fits into this groove between the condyles of the femur, and the patella articulates in this groove here. And there's quite a bit of force there And the key thing is to have the patella very centrally located and equally distributed forces on either of condyle of the femur as the patella articulates there. You can see a beautiful example of the menisci, these crescents of fibrocartilage that act as pads, these shock absorber pads underneath the condyles of the femur, the medial and lateral condyles of the femur. The medial meniscus is essentially all one piece with the tibial collateral ligament, and that's going to have some consequences in certain types of injuries, as we'll see. Here we can see a syndesmosis, where the proximal end of the fibula is attached to the tibia. There's a dissection, a cadaver dissection, showing the knee joint and the menisci and the two condyles of the femur and the location of the condylar surface for the patella to articulate and so forth. And you can see the tibial collateral ligament there and the fibular collateral ligament. That's very nicely done. Well, some common sports injuries to the knee that I'm sure you've heard of, so I thought I would just put them in here to explain a little bit more what is going on there. The anterior cruciate ligament we've already mentioned prevents the tibia from sort of escaping anteriorly out from under the femur, and if you have a particular type of a movement, like running at a high speed and suddenly stopping on one foot and maybe even simultaneously trying to cut to the opposite side, turn, in other words, your direction of motion, that can lead to a torn anterior cruciate ligament, in which case the tibia will move out from under the femur, a very difficult problem indeed, which will require a surgical repair if it's a full, complete tear. If laterally applied forces strike the joint, the knee joint, in other words, pushing the knee medially towards the midline of the body, then there could be some multiple injuries that take place in the knee. And this is also a pretty common injury in sports, where, say, football, where there's a lot of body contact, and if somebody hits the knee inadvertently with their body weight and pushing it medially, you may simultaneously tear the anterior cruciate ligament, the tibial collateral ligament, but also, because they're sort of fused with the meniscus, the medial meniscus may be torn as well. So that's a relatively common injury of the more severe injuries of the knee in football, for example. I don't know how often this happens in hockey to really produce this injury. You can look that up. Sorry, I got a little bit of a conflict going on there. And here's just a little arthroscopic picture. A lot of surgeries that are done to attempt to clean up injuries within the knee joint are done arthroscopically. In other words, a thin tube with a tiny camera attached to the tip of it is inserted through an incision around the knee, and tools can then be inserted through other tiny incisions around the knee, allowing for some repairs to be done. Some cleaning up typically is what's done, removing debris and chamfering, smoothing off edges of torn menisci and so forth, and all that can be done with the most minimal incisions in the knee. So it's pretty cool. So there's a little picture in there of some of the tissues. Other common knee injuries, runner's knee or patellofemoral knee pain syndrome, can be produced by either running and jumping sports, where you have repetitive impact forces on the knee, or just a lot of distance running that will sometimes create some overuse injury, some rubbing of the patella on the femur that leads eventually to some inflammation and pain. Also, if for some reason there's misalignment such that of the quadriceps group of muscles, the patella is pulled slightly off center as there's extension of the knee joint. When the tension is placed on the patella, that will also produce an imbalance of forces there, and an excess rubbing on one condyle, and eventually some inflammation and chronic pain may ensue, and it may require some physical therapy to figure out how to correct that imbalance. Bursitis. Bursitis can occur in any joint that has bursa. Kneeling, doing a lot of work for many hours at a time kneeling, such as occupational work on flooring, installing flooring or carpeting, can lead to bursitis. There's a the prepatellar bursa sits anterior to the patella, and that can become very inflamed. You can see how swollen the knee is here. Very painful swelling of the bursa must require some rest, and maybe even injecting some anti-inflammatory steroids into that bursa to help settle the inflammation down and speed up the recovery process. Okay, here's another very cool joint, the shoulder joint. Here is the scapula, the part of the scapula that forms the glenohumeral joint. The glenoid fossa or glenoid cavity articulates with the head of the humerus. We've seen a picture of that already. We've also kind of examined the bursa in the shoulder joint, as well as a tendon sheath in there. So we had a look at this picture before, and we can see the joint cavity here that's enclosed by the joint capsule. Here's part of the joint fibrous layer of the joint capsule, and more of the joint capsule. So, so that's how shallow the so-called socket of the ball and socket of the shoulder joint is. Tremendous freedom of movement, the most freedom of movement of any synovial joint, and the least stable of all the synovial joints. And here's a beautiful dissection, a bandsaw cut of the body in a coronal plane, showing the shoulder joint. You can see the acromion, the glenoid fossa, the head of the humerus, the diaphysis of the humerus, the joint capsule right here, and more of the joint capsule here, the joint cavity. It's just a wonderful illustration from real life of how this joint is constructed. More bursa, pictures of bursa and tendon sheaths and some of the ligaments that are present in the shoulder. You can see that there's a ligament that connects the coracoid process here to the acromion, and another ligament that connects the humerus to the coracoid process, as well as tendons of various muscles that help stabilize that joint. This is a very unstable joint. Very important to have some muscles that can provide stability for that joint. Here's another look at this glenohumeral joint, or the glenoid fossa, I should say, of the glenohumeral joint. You just removed the humerus altogether from the situation. Here, this surrounding connective tissue around the joint that's sort of continuous with the joint capsule is called the labrum of this ball and socket joint. Labrum, more medially, but just outside the actual joint surfaces of the two bones. Interestingly, here's the tendon of the biceps muscle, and maybe if I get a chance to, I'll mention later if the picture lends itself, but it sits right in the intertubercular groove of the humerus between the greater and lesser tubercle. There's a deep groove there, and this tendon just sits right in that groove with a nice tendon sheath on it. And here's a dissection showing the beautiful articular cartilage on the head of the humerus, and this very shallow glenoid fossa covered with articular cartilage also in the shoulder joint. So, major stability for this particular joint comes from the rotator cuff, it's called. Four muscles that, well, there's actually a fifth muscle at least that helps provide stability, but four major muscles that just attach to the scapula and reach over and grab the head of the humerus and hold it into the glenoid fossa. And those are the infraspinatus, supraspinatus, teres minor, and subscapularis muscles. Now, I'm going to show you a quick little sort of, I don't know what you call it, pen and ink drawing of those muscles. We will take a much closer look at those muscles and define them a little bit more in the laboratory after we finish Chapter 9 in the lecture, around the time we're doing Chapter 9. But I do want to illustrate the important nature of these muscles for stability of the shoulder joint. So the scapula is this very large, flat, triangular structure, and its posterior surface and anterior surface are completely covered by muscle fibers that then coalesce to form strong tendons that reach right around the head of the humerus and attach to the tubercles. So we have the subscapularis here on the anterior of the scapula, infraspinatus and supraspinatus, essentially all one muscle, but they're kind of separated because the scapular spine kind of cuts right down the middle of them like a mountain range. But these two fans of muscle come from opposite sides of the scapula and reach right around onto the superior surface of those tubercles, and as well as to the lateral surface of those tubercles, and just grab that humerus and hold that head right into the glenoid fossa. So strengthening those muscles is a must as you age. Otherwise, you're going to wind up tearing one of these tendons or jamming it in there. You can see there's not much space between the acromion and the head of the humerus and the tendons that are in there. And if you manage to get some inflammation going in there and things swell and begin to occupy more space, that's going to have there's going to be a runaway buildup of inflammation and pain in there. So you can have a rotator cuff injury. And to prevent that, you can just exercise these two large muscles, including the teres minor I mentioned down here. If you do internal and external rotation, it's called. So let's take a look at this woman's arm. Her humerus is in a medially rotated position, as you can tell from her forearm being right across her torso, and she's got a weighted cable and a handle in her hand, and she's going to move only her humerus. She's going to externally or laterally rotate her humerus using the infraspinatus and supraspinatus muscles, strengthening them, and do sets of repetitions. And then here we see her doing the opposite thing. She's going to medially rotate the humerus using only the subscapularis muscle against the weight that's on the end of this cable. So anyway, not to belabor that. Another, not common, but sports injury, if you are going to dislocate the shoulder, here's how it's probably going to go. It's going to go anteriorly and inferiorly. You can find some interesting pictures of how it looks on an athlete's body when their humerus is dislocated from the glenoid fossa. It'll kind of hang down, and we'll see the coracoid process sticking right out, and the acromion sticking out laterally, because now the humerus is no longer the most lateral structure here, as it should be. These bones are going to be, this bone, especially the coracoid or the acromion, is going to stick out, and the humerus is going to be hanging way down low. So sports injuries involving falls at speed onto the outstretched arm or contact between bodies can cause dislocation of the humerus. So in our next section, we'll tackle the elbow joint, the hip joint, the temporomandibular joint, and also some more diseases, inflammatory diseases and other diseases of joints.